introductions this evening. George Justison is our speaker, and he will be speaking on DO2, a topic near and dear to our heart. George is a friend and a colleague and goes back quite far with me. He is a graduate of, just to cover some of his CV. It would probably take me the rest of the time to cover all of the CV, so we'll take some snippets of it. He's a graduate of the Ohio State University Circ Tech program. He has held a myriad of positions in a myriad of places: chief perfusionist and a senior technologist for account development at Extracorporeal Technologies Incorporated. He's been a clinical instructor for many programs, including Oakland University's program, as well as a quality education manager for Fresenius Medical Care. He's still a clinical instructor for Midwestern University. He has held the position of clinical manager of perfusion at the University of Colorado Health at Denver Eastern Colorado VA Medical Center, and currently is the manager of perfusion services and extracorporeal life support director at the UCH Perfusion Simulation University of Colorado Hospital. And he's also on the faculty for the Cardiovascular Anesthesia Fellowship Program. So please join me in welcoming this very honored speaker tonight doing a presentation for us, George Justison.
Thank you, Jeff, very much for that introduction. And it is an honor to be here with you all tonight to discuss a topic very near and dear to our heart, and that is goal-directed perfusion, and looking at the opportunities to expand our definition of goal-directed perfusion and what the future looks like. Just some disclosures. Have no financial disclosures. Some data that I'm going to be talking about today is some internal quality improvement data. So we're going to kind of take the covers off and expose our own practice. It's for illustrative purposes only. It's not peer reviewed, and so you should take it as such. So this evening, we want to review the science behind goal-directed perfusion, talk about the classic definition, and really what is the foundation of GDP, explore some other opportunities, and discuss barriers to improving acute kidney injury in cardiac surgery and the future perspectives that holds on GDP. So let's start off with a couple definitions. The first one being a goal. A goal is simply the object of a person's ambition, an aim, or desired result. Directed means to control the operations of, or manage or govern to reach a desired result. And of course, we all know the word perfusion means to the passage of blood through blood vessels or other natural channels to an organ or a tissue. So those are important concepts to keep in mind. As a matter of fact, in one of the early textbooks on cardiopulmonary bypass by Grun and Stratton, they define the ultimate aim of perfusion is to provide satisfactory tissue gas exchange. And that's ultimately our job during cardiopulmonary bypass or during any type of extracorporeal life support, is to provide satisfactory tissue gas exchange. And so one of the fundamental concepts of goal-directed perfusion is, how do we measure satisfactory tissue gas exchange? The other important element that Galletti points out in his textbook is that each organism is its own control. And by that, he meant that if you measure tissue respiration at the patient level, then that will guide you to what oxygen delivery is needed. So this is how we get patient-centered or patient-specific goal-directed perfusion, is you really need to have a patient element to that. And then, matter of fact, the core principles of GDP today were explained by Galletti in 1962. And in his chapter on perfusion adequacy, he talks about things like oxygenator exhaust gas capnography and using that to measure the patient's carbon dioxide production. And that adequate blood flow is whatever the oxygen delivery is needed to maintain that normal respiratory quotient or maintain that balance between carbon dioxide production and oxygen consumption. And so many of the elements that you see today describing goal-directed perfusion, really, it's not new. It's been described by Galletti in 1962. But this is why having a patient element to goal-directed perfusion or your oxygen delivery is important, because as you know, we can have patients of many different dimensions, different heights, different weights, different body mass indexes, different genders, different ages, but they all have the same calculated body surface area. And if we simply rely on a BSA index blood flow or a cardiac index only, each of these patients would receive the same blood flow rate. But as you can imagine, each one of these individuals probably has very different oxygen consumptions and very different oxygen delivery needs. So that's why it's important in GDP to have a patient perspective, right? So just for review, in GDP parameters, there are 3 measured parameters that we talk about. Oxygen delivery, which is the product of oxygen content, arterial oxygen content, and blood flow, oxygen consumption, and carbon dioxide production, right? And these are often indexed to body surface area so that we can compare patients. And carbon dioxide production on cardiopulmonary bypass is a relatively easy thing to do if you employ exhaust gas capnography. It's simply the exhaust gas PCO2 times your gas flow. And then oftentimes is a better representation of a patient's true metabolic rate than their oxygen consumption. Also important in goal-directed perfusion are the derived ratios of these 3 measured parameters. And those are the oxygen extraction ratio, or what percentage of the delivered oxygen the patient is consuming, the oxygen delivery to carbon dioxide production ratio, the DO2 to VCO2 ratio. And this is important to ensure that your delivered oxygen is at a specific ratio or adequate for a current metabolic rate. And one that is infrequently used, but in our practice, we find very important, and that's the respiratory quotient. And that's the carbon dioxide production to oxygen consumption ratio. And in Galletti's book on perfusion adequacy, he states very clearly that the delivered oxygen that's needed is whatever is required to maintain this ratio normal. So, the discussion, right, of oxygen delivery or goal-directed perfusion, really goes back to 2005 and Ranucci. I think we've probably all seen this slide 100 times, where he changed the conversation in cardiac surgery from talking about low and high hematocrit to talking about low and high oxygen delivery. And that in patients who had a high oxygen delivery, whether you had a normal or low hematocrit, you had less acute kidney injury than in patients with a low DO2. And what's important about this paper is the size. It was over 1,000 patients. And he was actually measuring stage 2 AKI. And the value that Ranucci came up with was about 272, and that was his inflection point in his statistical analysis. So this is the first number, right, that stuck in everyone's mind was 272. And then in 2011, Philip DeSommer in a multi-institution study came to a similar conclusion that if you have an oxygen delivery greater than 262, you had much reduced, again, stage 2 AKI. But what's important about Philip's study was he also introduced then this concept of the DO2 VCO2 ratio and showed that if your ratio was greater than 5.3, again, reduced acute kidney injury. So this introduced us to this concept of oxygen delivery relative to a patient's metabolic rate. And what's important in these studies is they both had a very strong negative predictive value, right? So very strong association here with stage 2 acute kidney injury. And so again, a new number pops into the literature and into the conversation, this time 262, but in relationship to a DO2 VCO2 ratio greater than 5.3. More recently, Condello and group, this was published in 2020, compared several different techniques of perfusion management. One is oxygen delivery greater than 280, and the patient respiratory element was the oxygen extraction ratio, or the O2-ER. Remember, that's the VO2 divided by the DO2. So one leg was DO2 greater than 280, oxygen extraction less than 25%, compared to a cardiac index of 2.4 and an SVO2 greater than 75%. Their endpoint was measuring hyperlactemia, which they defined as greater than 3 millimoles per liter. And they made this soft association with hyperlactemia associated with increased postoperative creatinine. And what they found here was that if you used the DO2 and O2 extraction ratio method, that you had less lactate production and a better negative predictive value than a 2.4 index and an SVO2 of 75%. So this compared using goal-directed perfusion respiratory measurements compared to index blood flow and SVO2 alone, and found that to be more, about 16% more specific for hyperlactemia. And the reason for this is simple physiology. If we look at a normal oxygen delivery, which is somewhere around 800 mLs per minute, and a patient's oxygen consumption, which is about 250 mLs per minute, this leaves you with an oxygen extraction ratio of about 30% and an SVO2 of 70. But, excuse me, as that oxygen delivery starts to decrease, then in physiology, right, we extract more oxygen and we have a lower SVO2 to maintain that same oxygen consumption at 250. Well, eventually, as we decrease oxygen delivery even lower, we do not have enough delivered oxygen to support that oxygen consumption. And at this point, the oxygen consumption becomes dependent on the delivered oxygen. And at this point in time, we've reached limits of oxygen extraction. And so under this critical DO2 level, oxygen consumption is no longer guaranteed. And right, we produce ATP through anaerobic metabolism and subsequent lactate production. We see this same phenomenon in other types of extracorporeal support. This is a paper from Robert Bartlett looking at gas exchange and ECMO. And again, same thing, right? A normal ratio of oxygen delivery to oxygen consumption is about 5:1. And as we decrease that ratio, right, eventually we get to a point where it no longer supports oxygen consumption, and oxygen consumption becomes dependent on that delivered oxygen. But the value of that actual DO2 is dependent on the metabolic rate of the patient. This being a normal metabolic rate versus a patient in a hypermetabolic state. In order to maintain that same ratio, right, you need to have a much higher delivered oxygen level. And so this is why not having a portion of the patient component when talking about GDP really may give you confusing information on actual oxygen delivery targets. And I get this question a lot from people about, well, my mean DO2 in my patient population with no AKI is less than 280. And that may be true. It may be in that subset of patients that you're looking at, or in the patient profile in your particular hospital. It may be a lower value, but it's hard to assess whether that value is adequate or not if we don't put some relationship back to the patient's utilization of that oxygen. So either a DO2 VO2 ratio or a DO2 v CO2 ratio, or some measure of oxygen extraction, because we know that the DO2 to VO2 ratio tells you if your delivery is adequate for a current metabolic rate, but there's lots of reasons why the actual value of oxygen delivery might be different for you. Okay. So let's talk about carbon dioxide production. We talk about it in terms of the CO2 kinesis law. Carbon dioxide production along with oxygen consumption is normal. So for every mole of oxygen we consume, we produce a mole of carbon dioxide. But if we're in anaerobic respiration, we're not consuming oxygen, right? But we're still producing carbon dioxide. So this is why values like the respiratory quotient can be helpful for you in your perfusion management, because it will tell you the imbalance between carbon dioxide production and the amount of oxygen that the patient is consuming. Normally, this is about a 1:1 ratio. It has a range, and it's dependent on the substrate that the patient is using. And it tells us imbalance in oxygen delivery to tissue. And it also tells us the imbalance between anaerobic and aerobic respiration. So some of the tips to using the respiratory quotient is you must understand changes that happen from hypothermic vasoconstriction and manipulation of patient systemic vascular resistance. And you also need to understand changes with substrate metabolism, because patients with different body mass composition have different baseline respiratory quotients, where lean tissue has a respiratory quotient of about 0.6 and adipose tissue is on an average about 1.3. So these carbon dioxide production values, right, and ratios are really good early warning predictors of lactate production. And the problem with lactate and using that as a monitoring tool is it's just like creatinine monitoring in AKI, in that it is a latent marker, right? And but some of these other parameters like carbon dioxide production ratio, the DO2 VCO2 ratio, you can see as it drops below 6, we have this trend towards higher lactate production, and the respiratory quotient are all strong predictors of impending lactate production and much more real-time monitors that you can use to actually react to in cardiopulmonary bypass. Matter of fact, one of the things that we saw in the GIFT trial, and this is unpublished data from the GIFT trial, is you certainly see this trend as the DO2 VCO2 ratio drops, we see increasing lactate production. But one of the things that we saw is there was no hyperlactemia in this group that had a DO2 VCO2 ratio greater than 6. Right? So a lot of our discussion, right, around goal-directed perfusion has been related to acute kidney injury. And acute kidney injury, very prevalent in cardiac surgery, right? Reported to be as high as 20 to 50%. And we know that acute kidney injury has a direct impact on patients' length of stay, their infection rate, their cost of care, morbidity, and mortality. And we've learned through many of the published trials, which you can go read, and the GIFT trial, that particularly stage 1 AKI, or the mildest form of acute kidney injury, can be directly impacted by our perfusion management or our oxygen delivery. And we demonstrated that in the GIFT trial. Newland and Baker, in even larger trial, over 19,000 patients, directly related that oxygen delivery can help reduce all forms of acute kidney risk and injury. The other thing you need to be aware of, though, when you're reading literature about GDP and acute kidney injury is pay attention to the definitions, right? So stage 1 AKI can be 1.5 to 1.9 times baseline creatinine, right? And typically we look at that within the first 48 hours if we want to make it an intraoperative association, or an increase in the serum creatinine by 0.3, or a decrease in urine output. So we need to be careful when we're reading that we understand what the author's definition was, because some of them only consider creatinine increases. Some of them combine both the creatinine and urine output. And so if you're including both of those terms in your definition, it can impact the different rates that you may see published. But really, isn't our overall goal to decrease acute kidney injury, right, and cardiac surgery? And so from here on, that's kind of what we are going to talk about, is how other factors apply or work in influencing maybe AKI rates that you might see at your institution. we all know that acute kidney injury, right, is multifactorial. So if you think just keeping your oxygen delivery greater than 280 or 300 and you've got the answer, I'm here to tell you today that that's not right. Now, maintaining oxygen delivery above critical thresholds is important, and it is an important element. But what I want to explore with you today is how some of these other factors might be influencing what you're trying to demonstrate at your institution and your strategy for decreasing AKI, and how this is going to help us expand the definition of what is goal-directed perfusion in the future. So this was one of the early reports that we did on area under the curve, right? And so area under the curve, if you're not familiar with that, is the difference between a target value and an actual value multiplied by the time that you were below that threshold, right? So that's what area under the curve is. And we certainly saw in our early investigation of this that patients who get AKI had not only a lower nadir, right, DO2I, but they spent more time below that threshold. So as a result, they had a more negative area under the curve. But we also saw in that data that they had a significant lower DO2 VCO2 ratio. So this oxygen delivery was certainly not adequate, right, to support their current metabolic rate. We know that a normal DO2 VO2 or VCO2 ratio is about 5. But in bypass today, we're probably pushing that limit up to closer than 6. But there was also a group of patients who had a lower DO2, less than 270, which was the threshold we were using at that point, but did not get AKI. And the explanation for that is, even though they have a negative area under the curve because we were using that 270 threshold, we see that they had a normal or adequate DO2 VCO2 ratio. So this is why it's important to look at the patient component of GDP when you're looking for a target oxygen delivery value, because if your ratio is adequate, it may be a patient population that is tolerant to that lower oxygen delivery. So an oxygen delivery or a DO2 value alone really doesn't have a lot of meaning today unless you relate it back to some patient utilization value. So there's the first problem, right? Relating oxygen delivery to patient utilization. The second problem is area under the curve, or the amount of time that we spend below thresholds. And this has been repeated now in many studies. This was a great one from Newland and Baker in 2017 that showed that as the area under the curve got more negative, your probability of developing acute kidney injury went up with an odds ratio of about 2.7. And that was after adjusting for risk stratification and for red blood cell transfusion rates. More recently, Mukeda, right? So Mukeda looked at DO2 less than 300 for different time increments. So greater than 15 minutes or less than 15 minutes. And showed that both in long bypass runs and short bypass runs, that if you limited your excursions of DO2 less than 300 to less than 15 cumulative minutes, that you had a lower rate of acute kidney injury. So Low DO2 excursions are cumulative. You don't get that time back. And we see that in this paper from Oshida, which is published in the American Heart Association 2020, and again looked at this single largest area under the curve as being a significant factor in predicting acute kidney injury, right? So this is like a normal case where you have excursions both above and below. So these excursions above do not erase these negative excursions, right? And so certainly found DO2 300 with a area under the curve greater than 880. So this is a good paper for giving us a reference for what an AUC limit should be. Low hemoglobin, transfusion on bypass, right? All increase your risk of acute kidney injury. Magruder, Journal Thoracic Cardiovascular Surgery 2020. What is a couple important factors from this study? One is first, area under the curve of a DO2 target threshold of less than 280 was associated with prolonged ventilation, increased acute kidney injury in the early postoperative phase, but really was the first link to the STS composite morbidity and mortality score. And so Magruder demonstrated here in 834 patients, right, that large area under the curve independently associated with STS morbidity and mortality. He also demonstrated to us that the effect of area under the curve was greater than the effect of changing cardiac indexes or changing hemoglobins. The other interesting piece out of this study is they separated out their patient populations by isolated CABG patients versus all other STS index procedures, right? So your valves, your valve combination cases, etc. And so what you see here is in bold are the ones that are significant, and you see a more response or relationship between area under the curve and different DO2 levels in the other indexed procedure cases compared to the CABG cases. And so this raises the question of, are there different DO2 requirements for CABG versus other procedures, or is different patient populations based on their clinical pathology more responsive to oxygen delivery or different oxygen delivery targets? The other interesting piece of data from Magruder's study is this: the impact on preoperative glomerular filtration rate, or GFR, on the risk adjusted effect of DO2 less than 280. And what you can see here, the solid line is the median, and then these are the confidence intervals. And you can see as the GFR decreases, right, the impact of having low DO2 on predicting acute kidney injury becomes greater. So now here's another element, right, that comes into the mix in the complexity of explaining goal-directed perfusion in acute kidney injury. We now have DO2 level itself. We have DO2 relative to carbon dioxide production or metabolic rate. We have a time element, right? And now we're adding in potential complicating or confusing factors on the pathology of the patient and their preoperative renal health. And so here's our first slide from our own QI database. And, we're at an academic medical center here, so we do all kinds of cases, and everyone likes to think they have the sickest patients, but here's just some reality of our patient population. And I'm using this just as an illustration of how all these different parameters intertwine. So in our patient population, 48% of our patients have some level of renal dysfunction on the day of surgery. And we define renal dysfunction as a creatinine clearance less than 85, because that's where in the Euroscore calculation, you start to see stratification, right? Half of those patients have a GFR less than 60, right? So here's the distribution of creatinine clearance and GFR in patients with true or false renal dysfunction. The other things we know in our practice, and these values hold true over time, is renal dysfunction is greater in females than it is in males. And in male population, people with renal dysfunction have twice the rate of diabetes as female patients do. So these are some preoperative characteristics now that can be blended into our goal-directed perfusion strategies. As a matter of fact, we looked at this. Again, this is data from our QI database. And so we broke these renal insufficiency patients into two groups, a mild renal insufficiency patient group. And we looked at the impact of increasing DO2 targets on the reduction in acute kidney injury rates, right? Compared to patients who did not meet that DO2 target. And you can see in this mild form of dysfunction in both CABG and valve CABG combinations, as our DO2 target went up, the rate of AKI went down significantly, but the effect was a little bit greater in the CABG patient population. As their renal insufficiency got worse, so this is creatinine clearance from 50 to 67, as we increased the DO2 targets, we got mixed results. So at 280 had really no impact, matter of fact, an opposite impact. But if we went up to 300 and 330, we saw some continued reduction in the CABG patients, none in the other types of categories. So suggesting that, pathology or the disease process of the patient may have some impact in their responsiveness to your oxygen delivery target. And maybe they need a different oxygen delivery target. So another element to throw into the mix. All right, so there's two more elements of tissue perfusion, right? Tissue respiration that we're going to talk about today. I think we all certainly have to talk about mean arterial pressure management and cerebral blood flow autoregulation, because delirium is another postoperative complication like AKI. It's very prevalent and it's ripe for a solution. Right, we know that there's 4 mechanisms of cerebral autoregulation. I think classically we're taught, keep your pressure somewhere in this range and you'll be okay. But it's affected by many parameters, right? PCO2, pharmacology, temperature, patient history, etc. So in an attempt to define an optimal blood pressure during cardiopulmonary bypass, Horry and the Cerebral Autoregulation Study Group at Johns Hopkins, right? Cohort of 3 studies found that the optimal was about 78 and the lower limit of cerebral autoregulation around 65, the upper limit around 84. But there was quite the distribution, right, of what the optimal mean arterial pressure was in these 3 cohort studies. What's important to know then is, the goal was to get to a map patient-specific target. 71% crossed the lower limit, 52% crossed the upper limit, right? So a lot of cerebral autoregulation studies involve very complex measurement technologies, right? Measuring middle cerebral artery blood flow, jugular bulb saturations, etc. Not a real practical solution in the operating room. One that has some potential to be a useful application and to become part of a goal-directed cerebral or mean arterial pressure measurement strategy is this idea of cerebral oximetry index. And so what this is a plot of the NIRS, all right, or cerebral oximetry value, and the cerebral perfusion pressure. And as you plot these, you get to an area where as the cerebral perfusion pressure changes, there is no change in the NIRS values. And this is then your autoregulation threshold for this particular patient. And so they found in this case that in 94% of the patients, that average lower limit was about 66 millimeters of mercury. But again, a wide variation in patients. That's why you just can't, like oxygen delivery, you just can't pick a number and apply that number, right, to all of our patients, right? So this group also did a randomized trial where they used this technology where the lower limit mean arterial pressure on bypass was done using this cerebral oximetry index. They measured delirium using the CAM ICU score, which is used in probably 85% of cardiac surgery programs in the United States. Only the perfusionist knew which autoregulation monitoring was used, but they found a 45% reduction in the CAM ICU delirium rate if this patient-specific targeted mean arterial pressure methodology was used on bypass. So another example, right, of having a goal, managing to that goal. So another extension of goal-directed perfusion mindset from oxygen delivery now to mean arterial pressure, which again is something that is important in acute kidney injury as well. The third topic that I want to touch on briefly is goal-directed fluid management. And again, this is a topic, right? Fluid balance, peripheral edema, maintaining that optimal ratio for convective and conductive transfer is important. And there seems to be some confusion in the literature about this. I mean, this is one study that many of you are probably familiar with out of Duke that looked at conventional ultrafiltration. And, their conclusion was that in high ultrafiltration use greater than 32 mLs per kilogram, you had more AKI, and that the really didn't help in changing the hemoglobin values, AKI. It didn't really help, or I should say AKA, didn't really help in changing oxygen delivery. And they use more packed red blood cell transfusion. They also adjusted for, mean arterial pressure area under the curve as well. And that this high use of cuff was a stimulus for decreased urine output. And again, remember this decreased urine output ties into that definition of AKI. And we could spend a whole session just discussing merits of this case and the next couple ones. One of the other observations here is when you look at preoperatively, there was some difference, right, in the creatinine values in these different groups, although there were some similarities in their trends. So, we could argue about the preoperative renal health also and its impact on just volume management in general. We know that patients with, preoperative renal failure tend to have, lower hemoglobins, right? More anemic. They tend to have more endovascular, glycocalyx dysfunction as well. Great paper from our hosts, Mr. Al Stammers. Again, looking at Z-buff volume, found this association with increased Z-buff volume, right, and decreased intraoperative urine output. Again, likely to possibly have an impact, right, on postoperative AKI rates. A meta-analysis by Kendall. I think this is probably one of the last papers that Jeff Riley was a co-author on. Again, looked at MUF, CUF, Z-buff, and its impact on acute kidney injury, and using a definition of less than or greater than 2,900 mLs of ultrafiltrate. What was interesting to me in this paper is that they did break this out by patients who had a history of kidney insufficiency and patients who had no history. And again, found really that there was really no impact, maybe slightly favors ultrafiltration in some instances, but no impact. So I bring this up because fluid management, right, is one of the other complicating, right, factors that go into this big bag, right, this big mix of stimuluses for acute kidney injury. So this is really the big reveal of our program, and so this is where you get to be critical of our practice. This is data from the last 3 quarters, and I pulled this out just because it's illustrative of long trends. Remember, we've been doing GDP for over 10 years now, but what I wanted to show you here was, even though we practice goal-directed perfusion, our average AKI rate this year is about 25%. And it varies by quarter. And you may say, well, this is an alarming trend. But if I extend this data out for 2 years, 5 years, you'll see that this is just part of a normal variation that we have. And there's several explanations for it. And I bring these topics up because these are things you should be considering if you're trying to make sense in your own GDP data, right? So first of all, if you separate out patients who have no AKI versus AKI, right, 75, 24%, and you break those out based on whether they had preoperative renal insufficiency or not, then you start to see some differences. So if you look at those 24.7% of patients who had AKI, you can see that 13.4% of them had preoperative renal insufficiency. And so that's an explanation of, why did this group of pre-op renal insufficiency go on to get AKI versus this group, 33% of the patients who had it did not. But more importantly, is this group who got AKI and did not have pre-op renal insufficiency, overall that was 11.3%. It varies, right, by quarter. And so this would be really what we would call an adjusted AKI rate. This is people that we wouldn't have expected. What you'll see globally, if you look at our AKI patients, right, they are primarily urgent and emergent cases. So about 60% of them are either urgent or emergent. And here comes our very complex case mix that we have. Our largest group of patients are aortic surgeries, and we do quite a bit. Our number 3 most popular procedure here is transplants, and these are the number of patients by quarter who got AKI, and so you can see some trends here, right? Large number of aortic cases, which tend to be, dissections. They tend to be emergent, urgent cases, transplants, etc. And in fact, if you break out your data quarterly, you can see certainly in this quarter where there were the largest percentage of them, right? A big uptake in urgent and emergent cases. So more than 30% of them were urgent emergent. So this has to tie into not only your analysis of your data, but it also has to tie into your perfusion management plan for these patients, because many of these emergent and urgent patients come to us already under renal stress. And we are starting to learn in GDP that some of these different subsets of patients may respond to different oxygen delivery targets, and some of them may not.
Hey, George, we have a few minutes till the webinar was supposed to conclude, but could we move into questions soon, or?
We can. So let me wrap up one thing, if I may, okay? So what's the future of this, and how do we work this out? Well, it may come down to machine learning, right? So machine learning is a tool that will probably help us sort out all of these parameters that are associated with acute kidney injury. And there's several good studies. Here's one from Seng that included both preoperative, intraoperative, postoperative data. And you can see some of those most important features are urine output, transfusion hemoglobin, blood loss, preoperative renal health, right? Operative time. So all of these things interplay in that. And if we had robust electronic databases that included the goal-directed perfusion parameters, these may get more predictive. And as a matter of fact, this paper just recently published in 2023, look at the orange dots, those that include pre, intra, and postoperative variables were the most predictive. And that is a paper from Condello that relates all these different bypass parameters and their predictive value using machine learning at predicting AKI. So that's really the future, is using more robust analysis. So I will leave you with just a couple takeaway messages. If you want good GDP data, you must measure blood flow, and you have to relate DO2 to patient utilization, right? So goal-directed perfusion targets should be patient-specific. We should ensure that MAP is within an auto-regulation zone, and we should have specific fluid management urine output goals that adjust for preoperative risk factors. Many complex interrelated parameters determine your AKI rate. You need a unique plan for different patient populations, and machine learning may be the future for helping us to sort this out. Okay, so thank you very much for your attention. Thank you to Jeff and Matt and Al Stammers for putting this together. And I look forward to your questions.
Thanks so much, George. You gave us so much information on goal-directed perfusion. One of the questions that I think everyone would benefit from that was proposed in the comments here is, what is the best way to implement a DO2 VCO2 ratio to a practice that is resistant to change? So in other words, when you implemented GDP at the university, how did you operationalize all this and obtain buy-in?
Yeah, so you have to find someone who understands patient metabolic rate in surgery. I found anesthesia to be the closest ally and the person most interested in this. And so you have to start with just getting them to read some of the science in the papers and having that discussion, but then also data collection, right? So that's the first step. You got to know where you're at. Do you really know your AKI rate, and do you have it broken down by stages, right? And then can you relate what you know about bypass from any method of record keeping to that data?
Absolutely, definitely a challenging aspect of building that program. You talked a lot about different DO2I thresholds, and we've seen a ton of them in the literature: 260, 272, 280, 300. We are bombarded by all these thresholds. What can a perfusionist do surrounded by all these values when they are just monitoring DO2I in the OR to supplement their oxygen delivery? Is there something else we can couple with oxygen monitoring in the OR?
Well, the easiest one is, to just look at patient's oxygen extraction ratio, right? Because it's easy to calculate a patient's oxygen consumption, right? And then your extraction ratio is simply consumption divided by delivery. Now, be careful, though, in calculating oxygen consumption that you really believe the data elements going into that, primarily SVO2, because we do a lot of things in bypass that alter the SVO2, cooling, systemic vascular resistance manipulation, high arterial PaO2s, right? Those will all give you a false SVO2. And that's why we like to use the carbon dioxide production. It's not impacted by those potential errors in measurement.
Yeah, George, one of the questions that was asked on the forum was and you touched on it a bit, what effect you thought temperature might have with this role?
Yeah, so we know that there's a good paper in the pediatric literature that shows that you can reduce your oxygen delivery targets, right, as you cool. And it's about 27 mLs per minute per meter squared per degree C. You can drop it. The problem that we see, if you look at the full GDP profile, is, and you're looking specifically at the respiratory quotient, you'll see as you cool, you think the patient is consuming less oxygen because their calculated oxygen consumption goes down, but you'll see a big spike in their respiratory quotient, right? And that shows you how that patient is reacting to hypothermia, how they are vasoconstricting in response to that hypothermia, and that you may actually have underperfused tissue because you'll see that respiratory quotient spike. And a small change in temperature may oftentimes corrects that. So that's another element of goal-directed perfusion. If you have this full complement of values, you can also see patients' tolerance or intolerance to hypothermia.
George,
I just want to make it, sorry, Matthew, I didn't mean to cut you off there. I know we're beyond the top of the hour. If it's okay with everybody, I'll extend it 5 more minutes to 6:10, and then we'll do a wrap up and a sign off I know there's other questions to be asked. So Matthew, go ahead. I'm sorry to interrupt.
Well, there's a hot one in the chat. It says, does mannitol affect AKI? Does it help decrease AKI? I know, George, you've been doing some background work on mannitol. Talk a little bit about maybe the interaction between oxygen delivery and mannitol, or are they separate issues?
So I think the science on mannitol is a little mixed. However, you do have to consider the impact of any type of diuretic that you use. So whether it's mannitol, Lasix, Bumex, whatever, on the relationship between renal oxygen consumption and renal oxygen delivery, right? And so if you have a group of patients that may already be under some renal stress, adding additional work to the kidney, right? One of the most oxygen consumptive processes in the kidney is filtration, right? And so it may not be beneficial. I'm that's just my opinion. I'm saying in my study of this, the literature is all over the place.
Matthew, anything else you're seeing from the forum?
I am scrolling through, and we've got a ton that popped up near the end, so it's difficult to move through. But you know what, George, I wanted to get your opinion on something. There was a study that came out in 2022, and this relates to patients with different preoperative risk and the role of DO2. This is entitled "Goal-Directed Perfusion is not associated with the decrease in AKI in patients predicted to be at high risk for acute renal failure after cardiothoracic surgery." So when patients come in with a high risk for developing AKI post-surgery, is it too late for us, or as perfusionists, do we need to raise our DO2 targets? What are your thoughts on that?
So what we do today is we have kind of a staged approach. If it is a mild dysfunction, let's say creatinine clearance between 68 and 84, we will actually raise our DO2 target because we think those patients respond to that. Now, you have to remember, in a whole body, right, our normal oxygen delivery is like 330 mLs per minute per meter squared. So shouldn't that be your target, right? That's normal oxygen delivery index to BSA. And then to answer your question, though, as the renal insufficiency gets greater, we find them less responsive to increasing DO2 targets. And perhaps there is not a strong association in those cases with oxygen delivery, but maybe other elements of perfusion management are impactful. And so that's what I was trying to get to at the end. I don't think we'll sort that out unless we use more complex analysis tools like machine learning and artificial intelligence, right? To sort out these interrelated parameters, because sometimes what might be causal may not be statistically significant when you're trying to force it into, a linear regression model.
George, I'm going to take one last question from the field, and then we're going to wrap up. Actually, want to say hi to Robert Groom. He is asking the question: the QI data suggests that pre-op kidney function has a big effect on post-AKI. Has your center looked at delaying the timing of surgery to allow treatment of kidney function as an opportunity to reduce AKI?
We certainly have, Bob, and we try to do that. But also what I showed you is, 60% of those patients are urgent and emergent surgery. So, we really didn't have the opportunity necessarily to delay their surgical procedure. But when we have the opportunity, we do that. And we also, when we have the opportunity, send all of our anemic patients to iron infusion clinic as well.
George, I just want to take this opportunity to thank you for a phenomenal presentation. We could go on for probably the rest of the hour, to be honest, and I'd love to. But in the interest of time, we have to conclude things. Matthew, I want to thank you for co-moderating with me tonight on this presentation, and Maggie Ring behind the scenes. I also want to thank you for all the work that you've done to make this happen tonight. I also want to tell you guys about the next one coming up, but for some reason, oh, yeah, there it is. We have Kenichi Tanaka coming up on July 19th. And so we'd like to invite everybody out to that. Please put that on your calendars. That'll be our next session about Jehovah's Witnesses and undergoing complex cardiac surgery. Once again, I just want to thank everybody for attending tonight. Great presentation again, George. George's data is on the screen for you. Feel free to email him. If you can also email Matt or myself with any questions, and or if you have trouble with getting your certificates, please feel free to let us know. We'd be glad to help out with that. Thank you all. At this point, I'm going to sign off and say be healthy, and thanks for attending.
Thank you.